Thank you so much. Also, Dave, for inviting us to present, and great appreciate allowing us to discuss this topic. Like you said, it's something it's not just the patient; it's the family that's affected by this disease process. That's why I think of all, patient support groups is one of the most important ones that my patients have benefited from. So my topic today was specifically kind of what are signs, symptoms, and how do you diagnose narcolepsy? It's actually fairly straightforward for the most part process of working on this, but I'll talk about some of the other alternative diagnosis differential that you do have to consider. And I'm going to leave quite a bit of time at the end for questions. I only have about, I think, 18 slides, so that should leave us plenty of time for questions. All right. Everyone can see my slides? I'm assuming that's good. All right, what is narcolepsy? Well, we'll start with, we don't know exactly. We do know that narcolepsy with cataplexy, or this type 1 as we say, is pretty well delineated. It seems to be there's an area in the hypothalamus that does not make a protein, and that is actually pretty well delineated. Our treatment is directed specifically at that defect in some patients. So that part we do know, but other than that, we're still fairly ignorant of the entire process. I mean, it's been described since the 1800s. The very first description was around 1877. So it goes back that far to know what it was. But like I said, as far as what exactly is occurring, we still don't know. There's been this hypothesis of an autoimmune process. We don't know if that's necessarily true, because whenever you do a spinal tap or fluid analysis of brain fluid, there does not seem to be signs of inflammation on that. So we don't really find that that's an absolute, proven. There are some ideas of an autoimmune process, even if not, quote, inflammatory, because many of you probably remember the flu pandemic of 2009 and 2010. There was a specific flu vaccine, pandemics, and there was about a 15 times higher rate of narcolepsy in that subsequent year, 2 years. China, whenever the same pandemic occurred, I think they said there was a 10 times higher rate of narcolepsy described. So that's where some of this hint of an autoimmune process. Now that typically was autoimmune only in certain populations, so maybe it's an environmental exposure. So in large degree, we still just don't know the exact process. Twin studies is one thing I did want to touch on real quickly. And if you have monozygotic twins, basically the exact same DNA, even in that circumstance, only about somewhere between 25–30% of the time will both have narcolepsy. So even if you have the exact same DNA sequence, there's still something that we don't understand. And once again, is that some environmental or autoimmune exposure? We just don't really know. But that's kind of the background, basic physiology and what we do know. As far as a clinical diagnosis, it's a chronic neurological disease, primarily daytime sleepiness. Now, I'm going to talk about these other, what we call accessory symptoms, cataplexy, hypnagogic. Gogic, this simply means when you're going to sleep. Hypnopompic hallucinations are when you're waking up. Sleep paralysis, disrupted nocturnal sleep. I've got a few slides. We're going to talk about that later in more detail. And for years, we just simply said narcolepsy with cataplexy and narcolepsy without cataplexy. But the last International Classification of Sleep Disorders more formalized this by saying there is a, quote, type 1 and a type 2. And the type 1 was the patients that had cataplexy, and the type 2 was they met other criteria, meaning sleep onset REM on a nap test that we'll talk about also, but there was not the presence of cataplexy, and that's the main difference. Now, as I said, my other topic was other forms of hypersomnia. Guess what? Most of the time when you see someone sleepy, it's not narcolepsy. And I can't tell you how many times a month I see a patient like, oh, my uncle had cataplexy or had narcolepsy. And I'm like, oh, exactly. Well, he snored and he was sleepy all day, and he likely had sleep apnea rather than truly having narcolepsy. So a lot of times what the public calls, narcolepsy is simply sleepiness, and realize there's all kinds. The most common being the very first one right here, insufficient sleep. All of you know we're a sleep-deprived society, and when that person's falling asleep driving or falling asleep at the chair at work, the most likely thing right off the bat is insufficient sleep. Sleep apnea, I'm not going to spend much time. That's snoring, choking, apnea, typically overweight. Narcolepsy, which already obviously is our topic today. Delayed sleep phase, this quite often is related to the shift worker. They're sleepy because they're not getting enough sleep, because most of those are sleep deprived, but also if this is the time when their body's wanting to go to sleep, yet they're trying to go see a movie, go to dinner with family, they may be falling asleep, and that's what this delayed sleep phase with the shift work. Limb movement disorder, not a common cause of sleepiness in most people unless it's pretty disruptive sleep. And this is simply that your legs are moving, waking you up at night. Sedating medications, extremely common also. Many medications that we use, one of the most common side effects is actually both sleepiness and insomnia. Idiopathic hypersomnia, which we're going to talk about a little bit also. Depression. Depression kind of presents in two ways as far as effects on sleep. Quite often it's that early morning, wake up at 3 or 4, can't go back to sleep. But at the same time, there are a certain number of patients that present with this. I'm sleeping 10, 12 hours a day. I'm not motivated. I don't want to do anything else. And that's this kind of hypersomnia that we see. So idiopathic hypersomnia. As we say, idiopathic means we don't understand the process. One of my old attendings said idiopathic meant the patient had the pathology and the doctor was the idiot because they didn't know what it was. So that's basically the idea, is we do not know what's causing this hypersomnia, but we basically excluded all this list. It's not sleep apnea. They are getting enough sleep. It's not a medication. It's not a mood disorder. In the end, that's one of the most common things you have to exclude. And after even seeing patients 2 or 3 times and a few months into the process, I have to admit, I can't always tell. Many patients will deny they're depressed, but they kind of seem depressed when you see them. So that's why this idiopathic hypersomnia is a little harder to distinguish. The idea is they, for the most part, look like a narcoleptic. They're sleepy, they're getting enough sleep, they're falling asleep inappropriately, but they do not have the REM component, and they do not have the cataplexy component. And they have less of these accessory symptoms also. When you do the nap test, we'll talk about later, they do not have these sleep onset REM periods, because one of the pathognomonic things of narcolepsy is the cataplexy, and also this REM intrusion, as we say. So instead of all of us going into REM sleep after we've been asleep for 60, 90, 120 minutes, they may go into REM sleep within 5 minutes. And this back and forth between awake and either immediately into REM or into REM within a couple minutes is this pathognomonic kind of part of what narcolepsy is. There is one other thing that was not in the previous slide I used, this post-concussive. It's not necessarily recognized as much as it was in the past, and I think there's even some debate if it's a true entity, but I still see this probably a time or two a year. Pretty bad head trauma, and they're sleepy ever since that time. You'll even see this in some patients have a craniotomy, neurosurgical procedure. They just have this persistent sleepiness after some CNS, either insult, trauma, surgery, that just never quite goes away. And that is something that you will see also. Back to the idiopathic hypersomnia. It's more common in women, it seems, than men. Typically, it's in their 20s and 30s. We do divide this into long and short patients, meaning some will sleep 10, 11 hours a day, yet they're still sleepy. And then these idiopathic hypersomnia with short sleep are more of like 7 to 8, like the rest of us, yet they can't, quote, sleep the sleepiness away. They're still sleepy. And that's why we divide this idiopathic hypersomnia into long and short sleepers. So you can have a sleep talk with showing at least some EEG and some of the sleep recording. This middle, the third and fourth line here are the eye movements, and you can see these sharp movements here. And what this is simply showing a patient that was clearly awake, fell asleep, and immediately went into what we call REM sleep. And that's what my point was before about this narcolepsy, is this sudden transition. They're sitting there talking to you. They kind of nod their head down. You look back over a minute later, they're asleep. And then within a few minutes after that, sometimes you can even see it through their eyes. And the guy that originally described REM sleep was simply looking at a patient, and it was kids actually, and could see that their eyes were moving. And that's what you'll see in these patients. literally going into REM sleep at, if not sleep onset, within a minute or so. Prevalence and diagnosis. This is a huge variability. Turns out about the most common population is Japanese, Asian populations. Some of those will actually have an incidence of about 1 in 1,000. Overall, you take the next 2,000 people you see in the street, no matter where you are, about 1 in 2,000 have a diagnosis of narcolepsy. So it's not common, but then again, it's, you know, more common than probably many people do realize. So about 1 in 2,000 of all comers. But as I just said, that varies a huge amount. Turns out that Arab, Jewish Israelis, Arabs, they have like less than, you know, 1 in 10,000, it seems. So it does vary quite a bit. Different ethnic groups, and there is association even within ethnic groups with HLA, and HLA is simply your genetic markers. But it does seem overall probably Japanese or Asians are about the highest risk. The other interesting thing is, if you are a narcoleptic patient, what is the chance of you having a narcoleptic child? Even though there is some degree of this genetic inheritance, only about a 1% chance if you are a narcoleptic patient will you have a child with narcolepsy. And I already mentioned before, you've got monozygotic twins, basically genetically matched perfectly. One will have narcolepsy and the other one will not have narcolepsy. So that's what we call this discordance. And that's at least 60–70% of the time. Like I said before, there is this HLA. HLA is your kind of genetic, and there's this certain, we call it DQB10602. That is actually pretty strongly associated in some populations, Caucasians, Asians, but in other populations, African Americans specifically, that's not as a strong association. So even that genetic marker, and then in that genetic marker is probably more useful for either excluding or making the suspicion of narcolepsy much less than it is in making the diagnosis of narcolepsy, because it turns out that it's a very common genetic prevalence across many populations, yet most of those do not have narcolepsy. And if you even ask a patient population, you know, do they even know someone in their family? It's around 5 to 10% even know someone in their family with narcolepsy. So in the end, the basic idea is there's some degree of genetic inheritance, but it's fairly weak. Typical age is late teens or 20s. This delay in diagnosis is extremely common. Although I have to say, I think it's getting less. You know, I've done sleep medicine for over 20 years now. When I started, you'd see these, you know, very sad cases. You know, someone that's 18 years old and graduating high school and can barely read, and you know, just basically got a C in every class because the teacher, I think, wanted to move them on to the next grade or the next class. And you start talking to them, well, I was falling asleep in every single class. And in those years, in the 80s and 90s, quite often I think that either teachers or family members were not aware of it, so they did not get sent for testing. The patient was, kid was accused of being lazy, not trying. Quite often what they would actually be, it would occur is they'd get seen by a psychiatrist and get labeled ADHD and get put on medications. So they did get better and were more functional, but it was from a stimulant for ADHD rather than anyone figuring out that in reality what they probably have is narcolepsy. Like I said, there's all kinds of papers about a delay, 5, 10, 15 years in some patients. I just don't think that's quite as common as we used to see it, because nowadays, if you're that sleepy, you're going to get seen. And quite often they got sent to me for, they snore and it looks like sleep apnea. And that was what they were looking at. In reality, it was narcolepsy to begin with. All right, we're going to jump into the specific symptoms now, okay? Cataplexy. I don't know how many in the crowd have seen it. You can actually watch these videos. I didn't say it before, but I kind of was going to mention Dobermans are the canine model that we've used. There's a specific gene that they were able to localize in Dobermans, and one of the tests that they would do to see how effective a drug was they would put bowls of dog food and see how many minutes it took the dog to get through the second bowl, the third bowl. And because as soon as the dog would see the food, they'd get excited and they would actually go down. And you can actually see YouTube videos. There's several on the internet of this. There's actually a few videos of kids, of parents put it on, which is probably not entirely appropriate. But basically, in the end, the way I describe it to my patients, it's emotion-related muscle weakness, okay? It's extremely hard for us to kind of explain it to patients, either for them to comprehend or for us to explain it. And I've seen patients for 6 months and have seen them, you know, every 2 months, and this is their 4th visit. And actually even longer than that, I've seen patients a year or two, and I ask every time, you know, is there any emotion, you know, you laugh, you get upset, you get angry, you get surprised. Nope, nope, nothing. And after I've asked them that 6 times in 2 years, they'll say, you know what, I guess maybe I didn't understand, or maybe I just didn't think about it, but now I've realized that my daughter came and told me a joke and I started laughing, and I tried to get up out of the chair and I couldn't get out of the chair. And like I said, it can be very subtle. It's more often, I've got a slide here that kind of shows emotional trigger. And the final thing is, there is a certain percent of the narcoleptic population that they really can't describe the emotional trigger. And sometimes it's even anticipation. They're going to get their grade back in their class or a paper, and earlier that day they'll kind of feel this, but in reality, the emotion did not really, you know, occurred yet, but it's anticipation in some people. It's more often, it involves the truncal muscles. Hands, specifically the feet, not quite as often. Sometimes I even ask, does your head really get heavy? Does your face get heavy? So it's most common, like I said, arms, facial muscles, posture. And you see these most severe ones, they will completely go down. Every once in a while you see a narcoleptic that there was a suspicion of seizures for several months before they ever got sent to us. Positive emotions are more common than negative, and there are a handful of patients that only have the negative. They're surprised or get upset, they get angry. The other thing is, there's some degree of this muscle weakness with emotion in many people. You know, you probably, maybe yourself, if like someone tells you a joke and you laugh so hard you know that you went and sat down in a chair. Well, that's a more subtle form, not full cataplexy. So that is something that, you know, other people, or even people without narcolepsy, will have. Like I said, it's more common positive joking, laughing, excited, anticipation. You get the anger, you get the surprise, you get the scared. That weakness is a little less common than the positive emotions. Knee buckling, postural collapse. The thing about this consciousness, that's kind of one of the best ways to distinguish, you know, a true seizure, although you can have seizures with maintenance of consciousness also at the start. But some patients will go straight from a cataplexy episode into a sleep episode. You will see that sometimes. And it's pretty rare you see these last very long. Rarely that it's, you know, several minutes. The only time you see that is what we call status cataplecticus. If they were on an SSRI or some other medication and they were given that for depression because they never realized it was truly narcolepsy with cataplexy, and they stop it and they're high dose, some of those patients, that's the only time I've ever really seen anything like that, is where they kind of go from one cataplexy episode to the other. It's stopping a high dose SSRI and they never realized it was probably cataplexy to begin with. All right. Hallucinations. I already said this is hypnagogic, meaning waking up, hypnopompic. I don't really make that distinction as much because it's not that horribly important. It turns out that hypnagogic is more common in the population as a whole, meaning people without narcolepsy. Turns out 10-20% of people have this, and you yourself in the audience may have seen this. The most common thing I have seen and asked patients, you know, you're really tired, you're either on the couch falling asleep, or maybe you're already in bed falling asleep. Do you dream or kind of think someone called your name, or the doorbell rang, or even someone was in the room just when you're really tired? And like I said, 10-20% of patient population as a whole will experience this. It's just a little more real. These narcolepsy patients will have a hard time distinguishing if it's real or not. Once in a while, you have a patient that called 911 because they were convinced someone was in their house. So it's just a little more vivid to narcoleptic patients versus other non-narcoleptic patients. And the big thing is it happens more often. You know, I myself have had this happen, you know, every 6 months maybe. You kind of thought that the phone rang and it didn't really ring. But this is a weekly, monthly, and it's a little more distressing to these patients. Auditory is most common. Rarely have I seen a tactile. I saw a patient a few months ago, and they thought literally someone got in the bed, and they would roll over real fast because they were just absolutely convinced someone was in the bed, and turns out there wasn't. I have never seen myself olfactory where they actually smell, but once in a while you'll actually have that, but I've never seen that. Like I said, these can be very vivid to these patients compared to other non-narcoleptic patients. Sleep paralysis, same, very similar idea. At least 10, 20%, in some studies show even higher than that, patients will have sleep paralysis. And what this is, you're awake, but you can't move. But it does occur either out of sleep, either falling asleep, or in the middle of sleep, or waking up in the morning. Most common thing I see is someone that does wake up 5, 6 in the morning. They're starting to kind of get that sleep fragmentation, light sleep, and they're ready to get out of bed, and they wake up and they just can't move. It's kind of interesting because there's old, they used to call it the witch's hag was one. And you'll see this, like I said, associated with, in non-narcoleptic patients, quite often it'll be associated with nightmares and once again, anxiety kind of a thing. Once again, the hallucinations, some will actually even dream that someone's there causing this. There's a movie I saw last year that has sleep paralysis, kind of the main theme of the movie. Most of the time it's a pretty brief thing. It's interesting if they have a bed partner and the bed partner touches them, it'll typically, quote, break it. And that's, in some patients, it'll last so long that the problem is really how to tell. They kind of lose, they can't quantify time very well. And I've seen several patients and they will say, oh, I could not move for 10 minutes or 15 minutes. It turns out that I don't think that's probably really true. They just kind of have a hard time tracking time. But the interesting other part is what I mentioned is if someone touches them, that's typically a way that, quote, breaks it. This disturbed nocturnal sleep kind of came later. It was always about sleep-related hallucinations, sleep paralysis, an association with narcolepsy, but not diagnostic for narcolepsy. Cataplexy, I already kind of jumped over this. Cataplexy was actually considered pathognomonic. Some years ago, 20, 30, 40 years ago, the most common path for a diagnosis of narcolepsy is they'd have a cataplexy episode. They see a neurologist. The neurologist would exclude there's any other neurological disease, and they were diagnosed with narcolepsy. And cataplexy was essentially pathognomonic for it. They've kind of gotten away. There's very, very, very few cases of cataplexy that are not in the setting of narcolepsy. It basically requires a specific lesion within the brain at the hypothalamus is the only way you get cataplexy without narcolepsy. But we've kind of gotten, and I think the last ICSD said that just having cataplexy alone, you still should test them just to make sure there's nothing else going on. So it's not necessarily considered pathognomonic anymore, but in reality, cataplexy is. This disturbed nocturnal sleep kind of came about a little bit later. You will once in a while see a patient with narcolepsy and their complaint actually is insomnia more than hypersomnia, or more than this, I just, can't get enough sleep and I'm tired and I fall asleep at work and I fall asleep driving, I fall asleep on the train. You will see this kind of disturb, and that's what is quite often is so frustrating. I fall asleep 2 or 3 times a day and I can't stay awake and I'm so tired. I sleep for 30 minutes and then I sleep for an hour here and I get home from work and I take a 30-minute nap and then I go to bed because I'm so tired. Then I wake up at 3 in the morning and I can't go back to sleep. Or I wake up and it takes me 30 minutes an hour to go back to sleep, and then I start waking up every hour at 4 and 5 in the morning. So sometimes it can present with the sleep disruption almost as prominent as the daytime sleepiness. But that's not typical. That's fairly atypical still. Most patients are still complaining of, I am tired, I am sleepy, I'm falling asleep all day, and I can't hold my job down. I've been fired 3 times, and I had 2 car wrecks in the last year. This fragmented sleep is little night wakenings. Sometimes they'll have this difficulty going back to sleep. There's a little bit of literature about more depressed patients. Maybe you have a harder time going back to sleep. So is that a little bit of narcolepsy with overlap of other sleep disorders? And I do have a little slide I want to talk about that. Because one thing that we have noticed, almost every sleep disorder, that list I showed you about sleep apnea, about limb movements, even parasomnias, acting out dreams, or sleepwalking, sleep talking, essentially every sleep disorder occurs more commonly in a narcoleptic population. So you're not just, stuck with the, treatment of narcolepsy, the sleepiness and all that. essentially all these other sleep disorders occur more commonly. The other thing that we don't understand very well either, it's extremely common for weight gain, 20, 30 pounds at the time of diagnosis. It seems to be more often in the kids when they get diagnosed, but sometimes when I'll see a 20, 30-year-old that finally gets diagnosed, they will have some sleep apnea also, but it's very mild. You treat the apnea and the sleepiness never got better. So that is a fairly common presentation also. These arousals, stage N1 sleep, N1 just being the lighter sleep. So you do see this kind of disturbed, and this is kind of a picture of it. And this is nice because this was that original description of narcolepsy where if you do a 24-hour recording of a narcolepsy patient, they're not sleeping 12, 14 hours a day. What they're doing is they're sleeping 15 minutes, then they're sleeping 3 hours, then they're awake and it's disrupted, then they're sleeping 20 minutes here, 30 minutes here, 45 minutes here. And if you do a total recording, it's fairly similar, 7, 8, 9 hours of sleep to the quote control or healthy patients. The difference is you can see the disruption and the distribution over the entire 24-hour day rather than this consolidation typically around 8 hours at night. And this gets also into this whole REM idea. This R right here is REM sleep. See how they fell asleep at about 10:30 and they immediately go into REM sleep. See these naps, they go into REM sleep. Here they go into REM, here they go into REM. So it's just, we used to, or they still use the term gating. So it's just brain cycling in and out of REM sleep, stage N1, stage N2, stage N3. This cycling and these typical progression of sleep stages is completely off in patients with narcolepsy. All right, the specific criteria for narcolepsy. ICSD stands for International Classification of Sleep Disorders. As you can see, it's 3 because this is the 3rd version of it. This narcolepsy type 1, I already had this in my first slide. That was narcolepsy with cataplexy. That's this whole idea, and I'm not going to get into the hypercretin. This is that hypothalamic area. You'll see orexin is the other name. What happened is 2 groups were simultaneously working on this, and they published the papers within a few weeks of each other. One called it orexin, the other one called it hypercretin. So that's why we'll see 2 different terms for the same chemical, or same protein within the hypothalamus. And it's really, this is what the issue is with this type 1. So type 1, it seems the sleepiness and the REM intrusion and all that is related to the hypercretin. At the same time, the cataplexy is also. Because when you talk about the type 2, that's narcolepsy, so they have the REM issues, but they don't have the cataplexy. This hypocretin seems to be normal in them. So the hypocretin seems to explain the narcolepsy, the REM issues, and the cataplexy. Well, then what's going on with this type 2 population? Because they are sleepy, they're having the REM issues, but they're just not having the cataplexy part. Why is it a different, CNS process? We really don't know. So narcolepsy type 1, they have this, let me do a time check here. I'm not doing too, okay. Type A and B must be present. You've got this sleepiness, lapse into sleep, lasts for at least 3 months. This whole 3-month idea, quite often that's to exclude the depression, some other mood disorder. Was there some other viral process? You will see patients that have, what we're seeing right now are a lot of these patients with even COVID will have this hypersomnia too. So is it going to be similar to, when the viral pandemic, but there seems to be some relation there. Presence of 1 or more of this cataplexy and a mean sleep latency of less than 8 minutes, 2 or more sleep onset REMs, and within 15 minutes. I've got a slide that I'm going to talk about that. The type 2 is the mean sleep latency is once again less than 8 minutes. And you have these 2 sleep on REM periods. So the whole idea is we give you 20 minutes. Here, I'm going to talk about it with the MSLT. What this stands for is multiple sleep latency time, okay? Test, I'm sorry, multiple sleep latency test. This was developed years ago by kind of the first sleep researchers back in the 70s. And what they did is they would try to do this 2-hour day. What they would do is allow you to sleep for 20 minutes and you're awake for 40 minutes, and allow you to sleep 20 minutes, awake for 40 minutes. And what they were trying to do is look at the circadian. If you did these different kind of day night cycles, what would they look like? Well, what they realized when they put narcoleptics in this, during their 20-minute sleep, they would quite often go into REM. And if you look back at the picture I had right here, if you had them lay down here at 10 o'clock, well, what would they do? They'd go into REM. If you had them lay down at 12 o'clock, what would they do? They went into REM. You had them lay down at 2 p.m. So they kind of picked up on this. If you had them lay down and take a nap, they would go into REM. Look at the healthy patient. That would never occur. There was no nap. And if there was a nap, they wouldn't go into REM. So that's where they kind of picked up on this. And we use that as a way to diagnose it. So what happens is you bring the patient in, you do an overnight study. You don't do the overnight study to catch REM, to catch anything else. All you're doing it for is to exclude, sleep apnea, some other sleep disorder that can explain the sleepiness. You also do the overnight test to make sure that they're not sleeping 4 hours a night, because guess what? If you're sleeping 4 hours a night and you do that for days to weeks in a row, you will have REM sleep on naps. So you're doing the overnight study to exclude another process and to document they're getting enough adequate sleep. Well, now even it's a little more complicated than that, because this one night of adequate sleep doesn't reflect what you did 2 nights, 3 nights, 4 nights before the study. So what we ideally do is actigraphy, and that's where you use Jawbone, Fitbit, some device to measure sleep quantity to some degree. Some places will do a sleep diary just to document that, once again, you weren't, sleep deprived for several days before the study. My best story is I had a patient that was working at I can't remember what the store was, and they went and did the overnight shift and came in the next day to do their nap test. So you've got to have sufficient sleep for several days before to interpret a nap study is the point. And like I said, we're doing it to exclude other sleep disorders also. And then every 2 hours you lay down and take a nap. So if you woke up at 7 in the morning, you lay down at 9 o'clock, 9 a.m., 11 a.m., 1 p.m., 3 p.m., 5 p.m. And you did a nap and you see how long it takes you to fall asleep. And that's this 8-minute idea we already said here. And then whether or not you had sleep onset REM periods. So we give you a certain amount of time to, quote, go into REM sleep. And if you did that and you fell asleep in 3 minutes and you ran into REM sleep within 5 minutes, that is a sleep onset REM period. And that's what this is. I already mentioned you want to do it after a nighttime study. You want a minimum 6, ideally you want 7 or 8. It should be dark, quiet, comfortable temperature. Psychotropic drugs. What this is related to, if you're on many SSRIs, Prozac, Zoloft, Paxil, those suppress REM sleep. So if you stop it 2 days before and you come in and do the test, you can have, quote, REM rebound. So you're more likely to have that. So in an ideal world, we like a, quote, washout. They're off that 2-3 weeks. Prozac itself, takes at least 2 to 3 weeks to even be fully out of your body. Some patients, unfortunately, don't allow us to be off those medications for 2 weeks. So it's a little tougher at that point. Stimulants, Ritalin, Adderall, all those can affect your REM, so you want them off those medications. We try to avoid the smoking before the nap. Some patients, if they want to look better on the nap test, they'll do some jumping jacks and right before they come in and lay down to take the naps. The biggest thing in this test, in my experience over the years, is making sure the patient doesn't fall asleep between the naps. Because if you're in that 2-hour interval and you've truly got narcolepsy and you're not doing anything else, many will do a nap. And if the technician's not watching, what commonly happens is they're supposed to lay down at 2 p.m. to take the nap. But guess what? At 1:45, they fell asleep for 5 minutes. And even if they do for 5 minutes, that's long enough for them to, quote, catch up, go into REM sleep. And then the tech finds them and walks in and like, oh, you can't do that. Hook them up. And then they do their nap test 10 minutes later. You may miss the chance to catch a sleep onset REM. And I think that happens quite often. No caffeine, no bright light exposure. And that is the MSLT protocol, or multiple sleep latency test protocol. And that's a standard way we do it. All right, other tests. I already mentioned this, the CSF hypocretin. It requires a lumbar puncture. It can be diagnostic. Like I said, if you have a low enough test but once again, those patients typically have cataplexy. So if they've already got cataplexy, is there a reason to expose them to a lumbar puncture? It's a pretty safe procedure, but you can have headaches and other complications afterwards. And it's a send-out test, and quite often insurance won't pay for it. So I really have not sent it frequently in my practice. Genetic testing, I already mentioned, there is association with certain HLA haplotypes, but it's not diagnostic because, 20%, depending on what population you're talking about, what ethnic group will have that HLA haplotype. So it's not really that useful. I send it out rarely. And like I said, when I typically send it out, it's more of, hey, this makes narcolepsy much less likely because you don't even have the haplotype that's associated with it. But I already mentioned there's certain ethnic groups that they don't have that haplotype, so it's not typically horribly useful either. We'd love to get to a point where you can do a scan, some other tests, because the MSLTs, requires an overnight, it requires a whole day there in the lab. So ideally, we would like to have some way to diagnose it without that. The only thing is you get other information, the sleepiness on the MSLT, how long it takes you to fall asleep. I've had patients that fell asleep within 30 seconds on 5 naps. Well, that just makes you kind of hit home just how sleepy this patient really is. The other problem is, though, you see this patient and we do these sleepiness scales, how likely you are to fall asleep as a passenger reading a book and sitting, and they score extremely high on that test, but then they come in and do the nap test and it doesn't look that bad. And you'll ask, well, why? Well, it's a different environment. There's a technician watching me. It's such a false environment that I'm so alert. And there's some narcolepsy patients, whenever they are super vigilant, alert, or just anxious or out of their element or in a different scenario, they can kind of fight through it and stay more alert. So we know it's not necessarily a real world situation. So we would like to have a substitute for MSLT, but unfortunately at this time, there's no good substitute other than, like I said, the spinal tap, and if they've got cataplexy, then it's pretty clear cut at that point. And I think my time is up.
Thank you. Thank you so much for that clear and thorough presentation, Dr. Stevens. Now, we do actually have 10 questions, so I want to dig into that because I think we've got 12 minutes. So let's just jump straight in. There's a question here from Claire Burke, and she asks, can you have narcolepsy and idiopathic hypersomnia?
No, theoretically, you would fit in with one or the other. Like I said, what we use is for the narcolepsy, if you do the nap test and you got sleep onset during 2 naps, then idiopathic hypersomnia basically is excluded, okay? Now, in reality, like I already kind of mentioned, you will see a patient, you kind of think of narcolepsy, and they definitely have the sleep-related hallucinations. They've got the sleep paralysis, but they don't have cataplexy, or maybe it's a very subtle, I laugh and I kind of get a little weak, but it's not that bad, and it doesn't happen every time. Once in a while, you'll do the MSLT twice, or actually not even once in a while. I'd probably say 10, 20% of the time, I may treat the patient for a year or 2 years, or maybe they had the nap test before they saw me, and then I may repeat it again, and all of a sudden the second test, I've never done a third one before, but all of a sudden the second test, oh, they do have REM on the nap. And then there's some search, I'll never forget a patient I saw, and they were doing their MSLT on the day 9/11 occurred. Well, can you really do, another patient, they got a call that morning that their estranged father had died that they hadn't seen in 15 years, and they still stayed and did the nap test. Well, I would argue we probably should have aborted. I didn't find out until the next day that had happened. If you've got some major psychological or major, news or trauma you heard about, that's probably not the best day to be doing a nap test. But basically, there are patients that I could say you either have idiopathic hypersomnia or narcolepsy, and it's not clarified yet. And over time, typically it'll, declare as one or the other.
Thank you. Another question. Yes, thank you for that. We have another question, which I think refers to type 1 narcolepsy, which you clearly spoke about differentiating between type 2 on one of your slides. The question is, does stress count as an emotional trigger?
Yes, it would. Like I said, this is kind of a gray area. When you talk about stress, if they're anxious enough that it's distressful to the patient, yes, I would still say that probably is at least some form of cataplexy. Now, like I said, most often you get the laughter, happiness, more strongly associated with positive emotions. But if it can be stressful enough, I would at least consider that possible. And it would depend, okay, stress, but that's happening once a year. That'd be a little less likely. So it's a frequency, the strength of the association. And like I said before, there are some patients that they really seem to not be able to tell what emotion it is, and yet they've got the postural issues or the weakness of muscles, and they can't really put their finger on the emotion.
Thank you. Another question, is narcolepsy considered an autoimmune disorder?
Like I said, we think that. Now, when you talk about autoimmune being, quote, inflammatory, lupus and rheumatoid arthritis, they're all very inflammatory, right? Well, when we do CSF spinal fluid analysis, we don't see evidence of inflammation on the spinal fluid. So if we're calling this inflammatory, why wouldn't we see that? Well, is the inflammation so localized in this area in the hypothalamus, or maybe some other area we don't know yet, that it's so localized we can't pick up on the inflammation? Maybe it is. But so if you talk about autoimmune from a, quote, inflammatory standpoint, it doesn't seem like it's, quote, inflammatory. But when you talk about autoimmune, I already mentioned the pandemic, vaccine in 2009-10, that the rate of narcolepsy, went up 5-10 times after that flu vaccine was used. Then that's strong evidence there's autoimmune component to it, because you got the vaccine, you developed narcolepsy after that. But we don't know exactly how that may trigger it. Once again, that vaccine was triggering narcolepsy was much more common in that HLA. So it probably, what we're going to find is you've got this genetic predisposition. There's some patients that no matter what they got, no matter what vaccine, no matter what they're exposed to in the environment, they were never going to get it. It's probably a genetic predisposition that then has a vaccine, but many patients don't have a vaccine, right, that triggers it. It's a genetic predisposition that then gets triggered by some environmental or vaccine or some other exposure, is our best guess.
Yeah, it's a great segue actually into another question. Our son's narcolepsy with cataplexy began after getting the H1N1 vaccine when he was 8 at the time. He is now 19. Is there any research looking at this in the United States? I have read about research being done in Europe, but not in the US. Thank you.
Yes, that's exactly what I was talking about, the pandemics. Now, the thing I don't know is how much that vaccine was used in the US. I actually apologize. I meant to kind of dig into that a little bit more before I presented today. I think that it was mainly used in Europe more than the US, and but I can't say I know for sure. Maybe Dr. Ingram or Dr. Suzanne Stevens can weigh in on that. But I think that was more commonly used in Europe is why. And I can't say I know how much it was looked into the US. Here's the other issue is healthcare, because of universal healthcare and national health service in Europe, you can tell who got the vaccine and what date. It's much harder to track some association like that in the US because every health system has its own medical record system. So anything like that, even if it was used, would be tracked and would come to light much easier in Europe because the healthcare system is so much more organized and medical documentation is such more uniform. Dave, or you or Suzanne, do either one of you have, I can't say I know for sure about that.
Yeah. So I agree that what I've seen is it's essentially in Europe, and what I've seen published out of the United States, looking at patients in the United States, they have not seen that association.
Do you know if we use that vaccine in the US though?
We did not. We had a different version, so we did not see that same spike in the United States as best as I have seen.
And they thought it was not necessarily even the vaccine. What we do with these vaccines, you have the actual protein you want the body to make antibodies to, but we have an adjuvant. So we attach this to it. So it's not even the quote vaccine, it's what the vaccine got attached to, because what it gets attached to stimulates the immune system, and then you make the specific antibody. So it's this adjuvant was what they were even thinking. So it's not even the specific proteins of the vaccine, it's what the proteins got attached to that we think triggers this in some patients.
Yeah, I think, thank you for that answer. And the adjuvant then is key for the H1N1 vaccine in relationship to the onset of narcolepsy, but also might be worth looking at from a COVID perspective as we consider vaccines coming out potentially with similar adjuvants. Okay, another question, I think we've got time for one or two more. Does narcolepsy get worse with age?
That's very interesting because I have to say, I don't think it typically does. What is far more common in my experience is, you know, a 20-year-old, they're still fairly healthy, pretty thin. I diagnose, treat them, they're doing fine. But then I see them for 10 years and I look back and I'm like, oh my gosh, you've gained 45 pounds in the last 10 years. Then I do a sleep study and now they develop sleep apnea on top of the narcolepsy. It's kind of interesting also because with stimulants, Adderall, Ritalin, all these medications, over time, you'd think that they would be tachyphylactic, tolerant, and the medication doesn't work as well. And you will see that in some patients, but in my experience, most patients, they still continue to respond. Now, the thing is, you treat them, they're functional, they go to work, they're safe to drive, but they still, many of them, still feel like they're just not 100% like other people. But it's almost like their own reality, you know, and have they ever really felt that way? But it doesn't not seem that those patients over years, and I've seen 80-year-olds that are still on Adderall at 80 years and they've been on them for, you know, 40 years now and still seems like they respond.
Thank you. I think the weight, you know, we might hear more questions about weight gain. One specific question, is weight gain common in narcolepsy at onset? And is weight management an issue for people with narcolepsy in general? I think you may have started to answer that, but perhaps a comment about weight gain at onset of diagnosis.
And like I said, Dave, I think probably sees this even more than Dr. Ingram does. You know, there's been several papers though, like literally that month or a month or two later, they'll start gaining weight and they look back and I think the average is maybe 20, 25 pounds. That still happens in the adults that I diagnose, but it doesn't happen as often. And quite often what I've seen is they've started having a sleepiness, then they got a sleep study when they're 25, they have fairly mild, maybe moderate apnea. They got treated with CPAP or some other option for it, and their sleepiness never changed. So here the sleepiness got attributed to apnea because, well, that's what it is. And they never got further evaluation of narcolepsy. And then I worked them up more in depth, and sure enough, their NAP study shows they're severely sleepy. They have sleep onset REM. So even though it was attributed to sleep apnea for the last 5 years, in reality it had something else. And I think this pattern of the weight gain surrounding or coinciding with the diagnosis is more common in the younger population.
Yeah, I totally agree, Damien. We see that pretty frequently. That's a challenge. Trying to help with diet and nutrition, and also some medications can sometimes help with that as well. And I also want to reiterate one thing that you kind of talked about, which is this CSF hypocretin testing, which has just recently become commercially available. It used to be only be able to be done on a research basis, but really very recently is now commercially available through Mayo as a send out to them. And I've done it in a few patients now where we had clinical concern for narcolepsy, and they had a history that was concerning for cataplexy, but we really didn't feel comfortable getting them off of their antidepressants because they really needed them for their depression, and so our MSLT would have been limited by that. And it's been very helpful in a few circumstances, and has worked out really nicely. So that's been a huge help in terms of our diagnostic workup here recently.
Thank you, both of you, and Dr. Stevens, for your incredible presentation this morning.